by healthcare workers. So coming to the respiratory infection that we are facing currently, then the main route of transmission that has been recognized is a droplet transmission, and droplet transmission will happen when the particle is larger than 5 micrometer in size, and this will transfer into the air as droplet containing the infectious microorganism. Then this contact with mucous membrane of the nose, the mouth, or conjunctiva of the eye will result in an infection. And such kinds of droplet transmission will be produced during coughing, sneezing, or talking, or when we are doing procedure. But these things will remain airborne briefly and travel only about 1 meter or 3 feet. So the first principle is to keep ourselves away 1 meter from a patient who has potential risk of droplet transmission. For COVID-19, with extra care or with a safety margin, we have to be far, like 2 meters from a patient with a respiratory symptom. So when we have such patients, how can we place? So the placement of such patients, if available, private room is the best. So patients with a droplet transmission should be kept in a private room, but the door may be left open. Room air exhausted to the outside if facility is good, and negative air pressure is important. But for settings like the Ethiopian, a private room may not be available. So we can place patients in a room with having active similar infection or similar disease, but no other infection. So when we are saying cohorting, the patient should have similar disease, similar active disease. So these patients can be kept in the same room, but we have to separate their beds at least 1 meter. And for COVID-19, if the room is available, a 2 meter distance should be maintained between the patients. So regarding the healthcare workers, healthcare workers should apply respiratory protection, at least wearing a mask if within 1 meter or 3 feet of the patient. If available, we can wear a respirator, but if not, we can wear a surgical mask or a medical mask when we come close to the patient. And regarding patient transport, we have to limit transport of patients only to essential purposes. So we shouldn't have to let patients to go to laboratory or other services, and all services should be available while the patient is in the room. We can send blood investigation or urine analysis, stool examination, whatever investigation we need, we can send while the patient is in his room. But if a patient, if there is a need to send the patient to investigation, for CT scan, for X-ray, then we have to notify the area receiving the patient in advance. So the area will be prepared in advance, and the patient will get the service immediately without contaminating the rest of the patients. As well, one has to recognize that when we take patients for such purposes, when we are sending him, then we have to advise or strictly adhere to the infection control, which is wearing a mask. So the patient should wear a mask when he or she is transferred to such areas. The other important precaution is contact precaution. So we have to adhere to the contact precaution for all patients with potential of a droplet transmission, contact precaution should also be added. So contact precaution will prevent direct or indirect transmission from contact with contaminated surfaces or patients. Contact precaution is another important thing that we have to apply for patients with respiratory infection, and healthcare workers should adhere to the principles of using personal protective equipment, including gloves, masks, goggles, and others, and perform hand hygiene according to the 5 moments of hand hygiene. Use disposable or dedicated patient equipment when possible. So we have to dispose patient equipment which are single use, or we have to dedicate, we have to keep that equipment for that specific patient, or we have to clean or disinfect between use if sharing between patients is important. The other important thing is refrain from touching eyes, nose, or mouth with contaminated glove or hands. So after touching the patient, after caring for the patient, we have to avoid touching our eyes or face, and avoid contaminating surface not involved with direct patient cares like doors, lights, switch, mobile phone, and other things. We have to try to avoid touching all these things after touching the patient, and ensure appropriate and frequent environmental and equipment cleaning. So place in a single room if available. So all patients should be kept in a single room if available, but which is not practical for us. So cohorting patients with similar etiologic diagnosis is something that we can do, and still we have to maintain 1 meter between patients and avoid movement or transport of patients out of the hospital room. So the other transmission-based precaution, so far we have seen the droplet, the contact, and the other important transmission-based precaution is airborne precaution. So airborne precaution should be applied for patients with a possible transmission route of airborne. That means when the aerosol that is produced from the patient, or the droplet that produced from the patient is less than 5 micrometers, so it can travel more than 1 meter and contaminate the whole environment. So for such patients, we have to apply airborne precaution. Also, in all patients with severe acute respiratory infection that require droplet precaution and are undergoing aerosol generating procedure, aspiration or open sectioning or intubation, cardiopulmonary resuscitation, bronchoscopy, aerosolized nebulizer, non-invasive ventilation, and high flow oxygen, then during all this procedure we have to take not a droplet precaution. So automatically these things has a potential to produce aerosol, and airborne precaution should be applied. So airborne precaution should be applied at all time in patients suspected to have an emerging respiratory virus of potential concern, at all time in patients suspected to have tuberculosis, which is a common scenario in our country. Airborne precaution prevent transmission of very small droplet of all respiratory pathogens. So the healthcare worker use a particulate respirator like N95. The N95 is a particulate respirator which can filter 95% of the particulate. So there are other respirators like N99 which can filter 99%, but N95 is one approved respirator which can protect from acquiring infection through airborne route. So we have to use a particular respirator when we have airborne precaution. Gown, eye protection, and gloves are also important because these things can be easily transmitted from the conjunctiva, and if we are touching our hands, we can also transmit when we touch our face and nose or eyes. So the contact precaution should be applied all the time. Patients should be placed in a single room and avoid unnecessary movement. Still, in a country like Ethiopia where we can't afford a single room, then cohorting will apply also for airborne precaution. So all patients with similar illnesses can be kept in the same room. Airborne precaution, room ventilation should be a negative pressure room ventilation, and control direction of airflow is important. So for us, just closing the door is important, and other ventilating mechanism should be considered. So with limited resources in the era of COVID-19, frequently asked question is, when shall we use surgical mask or when shall we use respirator? So this is our guideline for the St. Paul group. So first of all, the surgical masks can be made of light cotton to synthetic material, but the respirators they contain multiple layers of filtering material, and the purpose of the surgical mask is to prevent moisture droplet expelled when the wearer speak, cough, or sneeze, and prevent an accidental splashing of the mouth and the face during certain procedure, and it filters particulate only greater than 5 micrometer, but the efficacy of the filtration depends on the how the mask is made, and there is no proven efficacy, or probably the efficacy is less than 70%. But the respirator, they service all purposes of the surgical mask, plus they filter 95% of the particulate matter that can contain infectious organisms, including less than 5 micrometer in sizes. So it has a capacity to filter 95% of the particulate. And when we compare it with the surgical mask, it is effective in airborne and droplet transmission. But one has to pay attention to the size of this respirator, because if it doesn't fit to our face, then it doesn't serve the purpose that is designed for it. But regarding the surgical mask, it should be large enough to cover nose, lower face, jaw, and facial hair. So surgical mask can be used in the COVID-19 era. Surgical mask can be used at the triage and pre-triage screening, during suspected patient evaluation by clinician, suspected or confirmed cases of COVID-19 patient, healthcare workers, surgical intervention of suspected or confirmed COVID-19 patients. So one last thing that we have to consider